My name is Devan Parrott, and I will be presenting the results from a randomized controlled trial comparing in-person delivery to telemedicine delivery in a brain injury coping skills group intervention. First, I want to orient you to the intervention itself. We call the intervention BICS, which stands for Brain Injury Coping Skills. BICS is an evidence-based group intervention designed and tested by Backhouse, Ibarra, and colleagues here at RHI. We have found over the last 2 studies that we've done that BICS can improve self-efficacy in both patients and caregivers in the brain injury population. BICS, although the number of sessions can vary, the version that I studied was 12 weekly sessions lasting 2 hours per session. The content covered within BICS, regardless of the number of sessions, always spans 6 modules designed to introduce brain injury and expectations for recovery, as well as provide tips on managing challenging problems and symptoms after brain injury, including depression and mood changes, as well as stress management and self-advocacy. More details on the actual BICS group, as well as previous evidence, are available in the 2 publications that you see cited here. This project actually began prior to the COVID pandemic, and the initial objectives for the study is that we wanted to design a BICS modification that would help patients and caregivers with transportation and scheduling issues. We've received wonderful reviews of BICS over the years from all of our patients and caregivers who have participated, and the only complaint we've ever had is that some of our patients with working caregivers would often struggle to make it to group each week. This ignores the many patients who weren't able to participate because of transportation barriers, as well as patients living in rural areas across the state or too far from RHI to attend a BICS group. So as you can imagine, now that COVID has created additional treatment barriers and increased the use of telemedicine, the results of this study are likely even more impactful than initially intended. The methods for this study are 2-part. So prior to this randomized controlled trial, we did complete a feasibility trial. During this feasibility trial, we tested the web-based content delivery, Zoom Health as a telemedicine platform, and we also piloted a training program for the technology that includes the iPads as well as the use of Zoom, and collected a lot of participant feedback and recommendations. I'm not going to present on that for this presentation. For this phase of the study, we're going to talk about the randomized controlled trial that we did after we made all of the modifications. So for this phase of the study, we randomly assigned participants to the telemedicine group and directly compared them to participants who were randomly assigned to the in-person group. So participants in both groups completed the same 12 sessions with the same content and the same facilitators. However, participants in the telemedicine group were provided preloaded iPads and structured training on using the iPads as well as Zoom. The iPads used in this study were the larger 12.9-inch iPad Pros. That would allow participants better viewing of the slide content as well as seeing and interacting with other participants. Depending on the specific content, participants would see each other, the slides, or both, depending on what the facilitator had up at that particular moment in the meeting. The facilitators had Apple Pencils as well, which would allow them to easily point out or mark up parts of the slides. You can see here in this demonstration here that there's a little circle here and then a line here. To keep the in-person and online groups consistent with each other, we also built in specific times for group discussions and Zoom polls. The goals of the 2 were to increase engagement, but also make it feel like the group members could engage with each other as well, like they would in an in-person group where you're sitting around a table together. The goal of the polls also allowed participants kind of a substitute for raising their hands in a group setting. If they could agree with something, these polls would allow them to show that they agreed. It also allowed them to acknowledge that something applied to them or We would have some polls that were geared towards specific content, just to increase engagement and help minimize that screen fatigue for those receiving the intervention online. Here's an idea of what a group discussion would look like on the iPad. So you can see everyone's face around the outside, and then the discussion topic would be in the center of the slide, or whatever slide was being discussed at that point, that could also be there. And the facilitator could be one of the faces around the outside, or the facilitator could be marking up things in the center, just depending on what content was being discussed. Here are some examples of the polls that we provided within Zoom to help reinforce some of the information provided in the slides. The questions here reflect content that would have been covered in the same session and are designed to help reinforce important concepts and increase engagement. We felt that these also were a way that we could kind of help the facilitators gauge the level of understanding and comprehension from the participants. When you're in an in-person group, it's more likely the participants, if they're confused, will say they're confused, or you can see it on their face and kind of, as you're presenting, tweak the things that you're saying a little bit if you see that the group is confused or questioning what you've said. So this was a way that the facilitator could kind of keep a pulse on the level of comprehension and things that maybe need to be reviewed or discussed a little more thoroughly. So we recruited 50 participants for the study, and we randomly assigned 25 to the in-person group and 25 to the telemedicine group. The study was completed in 3 waves, with each wave consisting of 14 to 20 participants, randomly split between in-person and telemedicine platforms. So that resulted in group sizes ranging from 7 to 10. The sample consisted of 28 participants with brain injury and 22 caregivers. Since our past work directly comparing BICS outcomes between participants with brain injury and their significant others found no group differences on outcomes, we decided to allow both survivors and caregivers to participate. Participants were allowed to participate with or without a partner, meaning both caregivers and survivors could participate alone. However, if partners consented together, they were randomized as a dyad so that they were in the group together. Caregiver roles primarily consisted of parents and spouses. Ultimately, we ended up with 14 survivors and 11 caregivers in each group. If you look at the diagnoses in the table, you will see that our patient sample included acquired brain injury, but was primarily TBI, and our caregiver sample primarily consisted of parents and partners. On average, their sample was 46 years old, primarily female, and 80% white. These trends were consistent after randomization with no significant differences between the groups on any of these key demographics. Primary outcome measures included self-efficacy and health-related quality of life. These constructs were measured with the Brain Injury Coping Skills Questionnaire, as well as various PROMIS subscales. Additionally, we looked at the Qualibri for quality of life specific to brain injury population, and additional data was also collected on group satisfaction and group climate. The BICS-Q is a self-efficacy measure designed for BICS participants and has been used and published in our previous work. The red box shows some sample items from the BICS-Q to give an idea of what the measure looks like. For example, I can cope with difficulties in my daily life, and then participants would rate that on a Likert scale. Statistically, using intent to treat analyses, both groups performed the same on the measure with no significant differences between the groups. However, looking at this plot, we were a bit concerned that the in-person group didn't show any change across time, which is not consistent with previous work. We did have a higher dropout in the in-person group due to the many reasons I mentioned before: transportation, conflicting schedules, even a few who dropped out after learning of their group assignment. Therefore, as a post hoc analysis, we completed the same analyses, but excluded the cases who failed to complete over 75% of the groups. The post hoc per protocol analysis also revealed no differences between the two groups, meaning that the telemedicine and the in-person group showed the same trend on the BICS-Q, but both groups this time showed improvement between baseline and post-treatment. And that's not surprising because you wouldn't expect someone who doesn't attend or drops out of the group to show an increase in self-efficacy if they're not attending the group. The reason we use intent to treat analyses is the concept in statistics that it's more ethical if someone is randomized than they're analyzed. So we always do intent to treat first because it could be something about the intervention that is causing that person to drop out of the study. And in this case, we really do believe that that is the reason that they dropped out. Most of them specifically said they wanted to be in the telemedicine group and they could not do the in-person group every week. Looking at the PROMIS self-efficacy scales, we found similar outcomes. So no significant group by time interactions were present, indicating no significant differences across the two groups. So that telemedicine group was doing about the same as the in-person group. Similarly, the PROMIS health-related quality of life, as well as the TBI-specific quality of life, the Qualibri, also showed no significant differences across the groups. So both groups behaved the same in terms of improvement on the outcome measures. The group climate questionnaire is a little bit different. This one consists of 3 subscales. We were looking at engagement, conflict, and avoidance. Statistically, the groups rate the levels of engagement and conflict the same, with both groups indicating high levels of engagement or working group atmosphere and low levels of conflict, defined as perceived anger or tension in the group. When looking at the avoidance subscale, this is defined as avoidance of personal responsibility. The two groups showed the biggest difference between scores, with one item standing out as the main cause for that difference. And that item is asking the members to rate the group's level of dependence upon the facilitator for direction. However, scores from both groups were still in the acceptable range for overall group cohesion, regardless of group. Here are the results for the telemedicine satisfaction survey. Looking specifically at the telemedicine group, 94% of the participants were overall fairly satisfied. Not surprisingly, the participants did provide lower ratings on items related to feeling connected, in addition to an item asking about the use of apps and assignments. In conclusion, this study supports the use of telemedicine for BICS and potentially lays the groundwork for the transition of other group interventions in the TBI population. Both groups in this study performed similarly across all outcome measures, indicating that telemedicine delivery may be as efficacious as in-person groups. However, one significant difference across the groups was the withdrawal rate after randomization, with significantly more withdrawals occurring in the in-person group. This unintended outcome is arguably one of the most important findings from this study, as it supports the need for more telemedicine initiatives and increased access to care for patients with transportation barriers or rural addresses. Future initiatives should focus on identification of patients best suited for telemedicine, as well as ways to increase group cohesion in these virtual settings. So thank you for your time. I also want to thank my co-authors, Dr. Summer Ibarra, Dr. Samantha Backhouse, and Claire Lyons. I also want to thank the Indiana Spinal Cord Brain Injury Research Fund for funding this project. Thank you.